Dear ESTS members and webinar attendees, my name is Lieve de Pieper, your moderator for today. This is already the 8th and the last educational webinar of the 2019-2020 series. Can everybody hear me?
Yes.
Yeah. Today will be about the non-primary lung malignancies, indications for surgical treatment of lung metastases. And I'm very proud to introduce you to Dr. Ugo Pastorino as a guest speaker. Ugo Pastorino is Director of the Thoracic Surgery Division at the Istituto Nazionale Tumori of Milan. He has been the Executive Director of the European School of Oncology and the Secretary General of the International Association for the Study of Lung Cancer. His surgical activity comprises, among others, bronchovascular reconstructions, management of T4 tumors with superior vena cava and major vessel resection reconstruction, and pulmonary metastasectomy. He has also authored almost 400 papers, and he was the first author of a landmark paper from the International Registry of Lung Metastases almost 20 years ago. But with this huge experience, I think Dr. Pastorino is our ideal guest speaker for today. Dr. Pastorino, please.
Good afternoon. Thank you, everybody. I will try to summarize from the very start what is the essential history of lung metastasectomy that I had the opportunity to leave from the very beginning. Can you see my slides?
Not yet. So there seems to be a problem with the sound. So we will just try to go back. Is there anyone else in the audience that has no sound? Or please, if you have any sound, please tick in your questions that we can see what happens. Sounds is okay. Okay, perfect. Then we can go further. So Professor Pastorino, the actions button, and then you can enable screen sharing. And share the entire screen. Okay, thank you, people. The sound is okay. It's fine. Okay, great. And then you go to your presentation.
Can I start? Okay.
And yeah, perfect.
Here we are.
Great, here we are.
I'm sure most of you don't know this man. Ed Beatty was a chief at the Memorial Sloan Kettering early, 80s, 70s, and he is the man who started systematic metastasectomy for osteogenic sarcoma in children. At that time, 80% of childhood osteosarcoma died because of lung metastasis. In the same institute, Markov was experimenting conservative surgery for osteogenic sarcoma with the limb sparing, and he introduced the induction chemotherapy at that time to provide in the time to prepare the prosthesis to have these kids remove their osteogenic sarcoma without removal of the entire leg. Well, Ed Beatty was the first to use systematic metastasectomy. When I visited him in 1980-81 as a fellow, I had the opportunity to see many of these girls and boys who lived over 10 years because of a systematic removal of lung metastasis. His first report is 1971, and then he updated his series in 1991 with 20 years. We started this pilot study in Milan in the early 80s, introducing systematic metastasectomy with median sternotomy and early bilateral resection of occult, at that time radiologically occult meds. And we compared the two periods until 81, where metastasectomy was seldom done, almost never done, with the following period where we operated each and every kid with the technically resectable metastasis, and we demonstrated that long-term survival was possible and also permanent cure. As you see, no one of the kids in the first period survived, while 25–30% survived in the second decade, and out of these, the only long-term survivors were those resected. We have recently updated the follow-up of this cohort together with the Rizzoli Institute of Bologna, with over 400 kids treated with systematic metastasectomy. We have now 20 to 40 years of follow-up. And I can tell you that beside the 50 year, there are actually no relapses. So it is possible to achieve a permanent cure in children with metastatic osteosarcoma through metastasectomy. I don't want to go too much on the experience of the international registry. As you know, we managed to demonstrate that the outcome is predictable. It is true that, as you see here, there is a survival of unresectable disease, but most of these had a second metastasectomy after chemotherapy. So the long-term survival are actually in the patient that received curative surgery in the second instance. But what is more important, it is predictable survival based on the number of lesions and the free interval. This proved to be true in osteosarcoma, as well as in colorectal cancer, where there were no survivors after incomplete resection at 5 years, and in kidney, and also in melanoma. Obviously, in melanoma, the life expectancy is poorer in general, but the capacity to predict survival is maintained. What is more important is if you apply the same methodology and calculate the life expectancy after the second metastasectomy, you find the same prognostic feature, the same chances of achieving long-term survival after the second. More recently, we have also demonstrated in slow-growing tumors such as salivary gland, parotid, essentially, adenoid cystic carcinoma, the metastasectomy can extend the life expectancy over the 20 years. There are obviously open questions. We don't know today whether eligibility should only be based on technical features or on biologic characteristics of the tumor. There is a big debate on the surgical approach, and it has been demonstrated that for appropriate patient with a limited peripheral disease, VATS can be better than open resection, but this is not true for every case. The volume of resection is still debatable. What is the safe resection margin for individual with multiple lesions? An even greater debate is related to nodal disease. For some, the presence of nodal metastasis is a contraindication to surgery. For others, it is not. And some apply the same criteria as for primary lung cancer, so induction chemotherapy for N1 disease before lung resection. The other debate is on what is the best use of alternative local therapy, such as stereotactic radiation therapy and radiofrequency ablation. Before going ahead, I would like you to answer two questions. One concerning your own experience, what the proportion of your current practice is dedicated to lung metastases, and what is your philosophy of approach to lung metastases. Can we start with the two questions?
Indeed. So the two questions are published. So if you go to your right sidebar for the audience, you can vote, and then we can see what happens. I'll give you another 15 seconds. We have more than 100 people watching. We only have 10 votes, so we should have some more active people, I think. Vote. You are anonymous. It's just to see what your current practice is, what people in Europe and around the world are doing. It's interesting to comment on that. So if you go to your right sidebar, you go to polls instead of questions, and there you can vote. We already have more than 50 votes right now, so that's very good. Maybe we can go a little bit more. Okay. Then everyone has made his choice. Then maybe Professor Pastorino can comment on that. Can you see the table?
I must say, I don't.
Not yet. Okay.
Well, but can you summarize for me?
Yes, I can. So the first question: what is the case mix? So what is the percentage of lung metastasis surgery taking of your total amount of procedures? 34%, so about 1/3 are saying between 0 and 10%. Half of the answers are between 10 and 25%. And then another 15% is between 25 and 40%, but almost no one, only 2% is saying more than 40%. So the majority, being half of the audience, is between 10 and 25%. Do you have any comments on that?
No, I think this is very useful to understand what is the commitment, engagement of different people in this. So we can go ahead with the consensus.
Wait, I think maybe I go for the answers on the second question as well.
Oh wait, you have the answer? Okay.
Yeah. So the second question was, what is the aim of your metastasis surgery? Tissue diagnosis, debulking, better survival, or permanent cure. And there, 83%, there they had multiple possibilities. So 83% is saying better survival. 34% is saying permanent cure. So 1 in 3 is saying permanent cure. And about 20% is saying tissue diagnosis.
Oh,
but no one is saying debulking.
Oh, that is good. 1/3 of people use metastasectomy with the intent of curing patient. That's great. That's Indeed. Very important. Can you see the expert consensus document?
Yeah, perfect.
Good. So let's start from this. This is a very crucial attempt to provide through the annals of thoracic surgery a proper consensus on metastasis. I must say, most of the questions remain open, but at least this paper poses a few important elements in the judgment. And probably the most important, the number one, is that with the present development of multimodality therapy, it is essential that the discussion is on resectability or indication to surgery is not left to the thoracic surgeon, but is part of a multidisciplinary team, and it is carefully individualized. This is another essential point that we are going to discuss when we will consider an attempt of a randomized evaluation, because the careful individualization and the choice of therapy for each patient is the essence to get the better results. So in general, we can assume, and this is part of the consensus, that whenever it is feasible, minimal invasive surgery should be used. But we have to consider that.
I just want to interrupt you because we seem to have a problem with the slides again. I don't know what happened, but we cannot see your slides. So can you enable screen sharing again? I hope this will be for the last time.
Of course.
I don't know what happened, but great.
It is possible? It is visible now?
It is visible.
Okay.
Okay. Yep.
So minimal invasive surgery, whenever possible, is a good option. But of course, we have to consider when you have multiple lesions that this may not be suitable for minimal invasive surgery. The goal is to achieve an R0. So we want to remove all visible lesion. This does not require palpation as it was 20, 30 years ago before the last development of CTs, but certainly it may be necessary to have a precision resection. So the goal remains removing all lesion with as least parenchyma as possible for patient with multiple lesions. In this consensus, it is stated that in general, the number of 3 is a number. But of course, this does not apply to each and every tumor. For sarcomas, the management of more than 5 or even more than 10 metastases is a common practice. This is completely different for epithelial tumors such as a colon, but still this number of 3 can only be considered a very general reference. Nodal sampling or dissection should be considered, and this is particularly true for epithelial cancer, and it is certainly true for metastatic colorectal cancer. But we have to be aware, and we are all aware, that the presence of a nodal metastasis compromises the chances of a cure in this patient. Thermal ablation or stereotactic radiotherapy are an option, but again, this it has to be measured with the chances of obtaining a complete and parenchymally safe resection when multiple lesions are involved. So I would say that the number of 3 applies even more to alternative therapies, non-surgical therapies, such as stereotactic ablation, because it is very difficult to deliver proper curative radiation or even more radiofrequency if you have more than 3 lesions. So again, in every patient, the choice should be individualized, and we must be prepared to combine surgical with the non-surgical local therapy. In 2015, Dirk van Rendonk, and certainly is an expert thoracic surgeon in the European community, tried to make a summary of what is the present status of pulmonary metastasectomy, and say it is a common practice, but strong evidence is lacking. I'm not entirely in agreement with this assumption, and particularly when he states that the results of a randomized trial for colorectal metastasis are awaited to make to have a clearer perception of the efficacy of pulmonary metastasectomy. Well, this trial was published last year in Trials, And the results are quite distant from what we may consider a satisfactory answer, because this trial was aiming at randomizing 500 individuals, and in 6 years managed to recruit and randomize only 65 individuals. As you see, out of 500 expected and 400, more than 400 eligible, only 93 were randomized, and this represents less than 1 case per year for every center. Now, assuming that a trial that randomizes only 1 or less than 1 case per year in each center is really impossible to evaluate in terms of a selection. What are the criteria for selection of these patients? Do these patients represent the reality of our clinical practice? I think they don't. I think that the selection in this particular trial was just on the opposite side, and was piloted by a prejudice against the surgery in the first instance. Well, in the attempt to improve the recruitment, a new center was added, a center from Serbia, and this center recruited on its own, and in a short period, 1/3 of the patient. But still, in the new presentation of the trial that was published very recently on EPUB, you see that there are less than 50 patients in each arm. And what is quite difficult to understand for me is why in the metastasectomy arm only 1/3 of the patients received chemotherapy. Another thing that is very difficult to understand is the shape of this curve, because it's very unlikely that in a surgical curve you have the first 2 years flat, and then you start see a patient dying from the 3rd year on. This is not the shape of the curves that we are used to see. I want to discuss with you another paper that has been published 2 years ago, and it is based on the SEER database. The SEER database is, in my view, the complement to randomized clinical trial. I'm not saying it is a replacement. I'm saying it's a complement, because in the present system of a clinical trial, the selection process that is necessary to reach the target is such that it is not at all certain that the patient accrued in a randomized trial represent the population. So the SEER data are a way to try to test what is the reality of a clinical practice in an unselected manner. Now, this paper reported the result in over 20,000 metastatic colorectal adenocarcinomas, and the results of this trial are quite interesting, because they prove that the difference in the outcome of liver metastases that represent by far the most common site of metastatic disease in colorectal cancer, and in this series there are more than 13,000 patients that suffered from liver metastasis. As you see, the survival of a patient treated with the surgery was far greater than the survival of a patient treated without surgery, which conferred a survival expectancy of less than 10% compared to 20% in surgical. And this is and this arm includes the non-surgical treatment, local therapies for liver metastases that are becoming more and more popular. In the same paper, the number of patients with isolated lung metastases was approximately 10% of the liver metastases. Yes, you see 1,500 patients. But in this group, the expected survival for lung metastases treated without a surgery was about 15%, while the survival of the surgically treated patient was above 40%. So in a general population which is by far larger of many times, and it is unselected, you see what is the expected survival of the general population of lung metastases from colorectal that are not treated by surgery, but may be treated with other local therapies. For the purpose of this webinar, I have looked at all the cancer adenocarcinoma from the colon that we treated in the last 15 years, and it is more than 400 individuals, 400 patients, and the survival is about 50% at 5 years. And the survival is not influenced by the number of metastasectomies. As you see, patients with a single metastasectomy in green have more or less the same survival of a patient with a multiple systematic repeated metastasectomy. To me, the 50% life expectancy for surgical management of lung metastasis from colorectal cancer is the standard outcome expected. Mm-hmm. I want to share with you another recent, let's say, discovery from unselected population. We have studied extensively the role of inflammatory status, chronic inflammatory status measurable by CRP, C-reactive protein, before or immediately after surgery. We have studied this in screening individuals. We have studied this in a large series of primary lung cancer, and we have proven that inflammatory status is an important determinant of the life expectancy within the same age, stage, and histology. In this paper that was published last year on the Annals of Surgical Oncology, we reported almost 900 consecutive patients undergoing the first pulmonary resection for metastatic disease for all causes. And 2/3 had a single surgical procedure and 1/3 had multiple metastasectomies. Now, the difference in life expectancy and total survival related to the pre or immediately postoperative levels of CRP was striking. That means inflammatory status is able to influence the life expectancy at 5 and also extending at 10 years. This, in my view, is one of those biological elements that should be explored in our future practice and research. We know that chronic inflammatory status is related to the immune profile, is related to a certain degree of immune suppression, and this is something that can be modified. So one area of exploration of prospective clinical trials, in my view, is not surgery versus non-surgery. In my view, the prospect of improvement is using randomization to study potentially innovative therapies to prevent the metastatic spread, also in individuals with oligometastatic disease. So my conclusion from this for this webinar is that we live in an era of personalized therapy. So the real question is not whether surgical metastasectomy is better than nothing. The real question is how to use at best surgical metastasectomy to improve the therapy and the life expectancy of each patient. And in a world of multimodality therapies and multimodality approach, the real question is what is the best therapy for the individual patient, not what is the therapy that can be used and offer the same prospects to everyone. So the randomization is always difficult in the field of surgery because we know that there is a strong prejudice from the physicians and from the patients on one side or the others, and so the patient and doctor choose if they want to offer, propose, or receive surgical therapy for metastatic disease, oligometastatic disease. So the randomization is extremely difficult. I would say that the attempt in the future will be to use at best our knowledge to integrate systemic therapy and local therapy, and also to integrate surgical metastasectomy with other local therapies to improve the long-term survival and the cure. And the field of immune modulation, immune control, inflammatory status are all aspects that should be addressed by prospective trial, where the question is, how can we improve a life expectancy that is already quite good? Because 50% at 5 years, to me, is quite good, but can we improve this further? So this is the question. Thank you.
Okay, thank you very much, Professor Pastorino. If you stop screen sharing, yes, then we can see you back. And you can see us back. Disable screen share.
Okay.
Indeed.
Okay.
Okay. You see us again because my computer is doing having.
No, I see you perfectly.
Okay, no problem. I hear you, so I'll leave it like that. Otherwise, we'll have troubles again. But I still have a problem with the questions. I had one question for you about this randomization and not randomizing patients. I think if you look at the SEER database, you could have some bias, some selection bias in patients undergoing surgery who were maybe having metastasis with a better prognosis on beforehand. How could we prevent this if we do that kind of research? Because you are definitely not in favor of the randomized trials. If I
no, don't put in my mouth what I have never. I have randomized more patients, I think, than the average, but several times more patients than the average surgeons worldwide. I have randomized thousands of patients. So it is not I'm not saying that randomization is no good. I'm just saying that sometimes the basic question, which is ignorance on what is better, is not perfectly answered by random allocation. So random allocation means we have no way to modulate our choice. The choice is equal for everyone. We have to assume that the choice is the same for every patient, and so the answer will be the same for every patient. What I am saying is we are not in this condition because we don't know exactly if the choice is the same and should be attributed simply by a random allocation, because we can and we have to select individuals according to a number of features. And adjusting for all these features can be very difficult or impossible. Now, if you have a system of randomization that only accrue 5% of the patient or less than 5%, you have the same chance of a bias that you have with the SEER data. I mean, in the end, the aim for us is to cure more patients. I don't even care what is the reason if I can make this individual live. And I'm not so worried by attributing, the worth or the value to one therapy in a condition where we have to apply several therapies together, but possibly different from one patient to the other. So the concept of a random assignment is simply unfeasible. Because we don't randomize individuals. I mean, in this English trial, the assumption was that 500 individuals would be enough. For a non-inferiority trial, I think that 500 individuals are not enough. And the number that was accrued was less than 10%. And so it was far less than the minimum conceivable for a randomized trial. I'm saying that the reality is different, and we have to use all our knowledge to try to offer the best therapy.
Okay, thank you. It was not very kind of me, but indeed it was just to see what your reaction on that was. I have a problem with reading the questions, but I think you can read them in your right sidebar. And I think we can start from below with the first one being, should we start with a lymph node dissection? And if frozen section is positive, abort and go to abort our metastasectomy. I will let you answer on this question. I will just log out and log in again, and I hope then we can I can help you better. Okay. Did you see that question?
No, but you read this very well for me.
So should we start our lymph node dissection, and if frozen section is positive, should we go further with metastasectomy or abort?
Well, it depends on the tumor. I mean, we are putting a systematic nodal mapping in colorectal. Yes, we do it for kidney cancer. We don't do it for sarcomas, for example. So it depends on the type of tumor. For the primary colorectal, which is probably the most relevant in this area, yes, we do the mapping and we do frozen section. And the choice to go on depends on the resection volume. Obviously, if we have to do a major resection for nodal disease, we may decide to stop the surgery. If we can have a complete dissection of all the nodes and a conservative lung resection, we go ahead, but we may not to offer redo surgery to the patient if they has a relapse.
Okay.
So it depends on.
Okay.
But for the colorectal, we don't do surgery without systemic chemotherapy at the time of a lung mets. We don't do primary resection of lung metastasis in colorectal cancer without induction chemotherapy. So it's a different approach.
Okay. Then another question was, what do you recommend for metastasectomy, laser or VATS? I think you already said the answer. That's a little bit, laser or VATS, indeed.
Well, we tried for a patient with a solitary lesion, we want to have a good margin and the minimal invasive approach. For a patient with the multiple lesion, and multiple can be more than 10, we want to save as much lung as possible, and so we don't attempt, thoracoscopic resection, because we want to do precision resection with the 3 millimeter around each nodule, and sometimes the nodule are 20, 30. So these are the two extreme. Obviously, in the middle of these two extreme, you have individual with the 2 or 3 lesions that are amenable to wedge stapling, thoracoscopic close approach. Then you have to decide how many lung you are wasting, and again you want to know if the closed approach enables you to do a proper nodal mapping, if this is convenient, as in colorectal. So there are areas in the middle where the choice can be difficult. In this case, we start with VATS, and we may simply extend slightly the approach if the closed approach is not sufficient. So we accept the 2 steps.
Okay. Then a question: do you have any experience of a single recurrent hepatocellular carcinoma in the lung?
You mean yes? Yeah. We have a program of lung resection and lung transplantation for the primary hepatocellular carcinoma, and we have quite a number of individuals that are referred to us after liver transplantation for a single metastasis, and we do it. We do resection and sometimes even a repeated resection for more than 1 relapse in the lung.
And
the outcome is not bad.
Sorry?
The outcome is not bad, but they are a few cases, of course.
Okay. Then, it's all very specific questions. Would you suggest surgery without aiming to a complete resection in thyroid metastasis disease? Because the MDT suggested cytoreduction in thyroid metastatic disease, this person says, for a better systemic therapy response, but he couldn't find any good evidence. So, question to you.
Well, it is a matter of the choice from the nuclear medicine physician. I mean, if they think that cytoreduction can significantly improve the efficacy of metabolic therapy, we may consider that, but it is rarely the case. So it's more a theoretical than a practical question, and often metastatic thyroid cancer has a very good prognosis, even without metastasectomy.
Okay. Then another question: do you follow any other prognostic biomarkers? So we talked about, or you talked about CRP, but let's say CA19-9, CEA, other prognostic factors of tumors?
No, we use this marker in the follow-up if the primary tumor had expressed a high level of the marker, but we don't use this marker to guide our decision. And even CRP is not at all used to guide our decision. My hope is that we will be able to modify the inflammatory profile in the future, not to change the indication to surgery, but to change the outcome and maybe reduce the complication. This is not true for metastasectomy, but it is true for primary lung cancer, where the level of complication drops if you can control immune profile and inflammatory status. But this is not to choose whom should be operated, and even the other blood marker we may use to trace the relapse, but not to decide whether operate or not.
Okay. Another interesting question to me is, would you consider to perform a pneumonectomy for lung metastasis if you have, for instance, a very central one and you can only do a pneumonectomy?
Well, we have published with Bob Ginsberg a paper based on the registry many years ago. Unfortunately, Bob is not with us anymore, but we demonstrated that in a proper condition, and it is exceptionally rare indication, but in proper condition, pneumonectomy can be curative. So we have used them, and I think it shouldn't be a complete, let's say, contraindication, but it has to be applied to very, very extremely selected cases. Sometimes in colorectal, you have a local relapses. You have more than one local relapse at the nodal site, for example, and this can be amenable to curative salvage through pneumonectomy. But these are exceptionally rare cases where you have to measure the complication rate and compare it to the chances of a permanent cure.
Okay. And then some questions about timing. The first one is, what is the best timing to operate in synchronous metastasis after the radical treatment of the primary site? Is it before or after the chemotherapy?
As I said, we never do metastasectomy in a chemosensitive patients or tumors before systemic therapy. So if the treatment is potentially sensitive to chemotherapy, it is mandatory for us to offer chemotherapy first. The problem is in osteosarcoma, for example, which is an example of a typically kids presenting or adults presenting with the synchronous metastasis, and we have to remove the metastases, lung metastasis, before doing radical surgery such as amputation. So if the individual is at risk of amputation or major primary surgery, we want to be sure that the lung is clean. So we do metastasectomy before the primary tumor therapy surgery. Okay. But always after induction chemo. And in fact, in osteosarcoma, synchronous lung metastases do better than early recurrent metastasis. So the metastasis occurring within 2 years from the primary diagnosis are worse than synchronous because they represent chemo-resistant disease, while synchronous metastases don't.
Okay. Then a question from your colleague Dirk van Raamdonk. He thanks you for the webinar. And what is your attitude towards synchronous versus metachronous metastasis? Do you have any advice on the best timing? For synchronous as well as metachronous, same?
No. Well, as I said, for synchronous metastasis, we make the decision after induction, and it depends on on the chances that the patient has to have a metastasis in other sites. And this is completely different from sarcomas and other tumors. So the approach to synchronous metastasis after induction depends on the primary tumor and the expected outcome. But if the primary has been properly controlled and the surgery is feasible, sometimes we do one side, because often they are bilateral. We do one side and we do chemotherapy again and wait for the outcome of the operated side before doing the opposite side, which sometimes may be several months. If there is the chance of a response to chemotherapy, a further response to chemotherapy.
Okay, and then about the size and the number of the metastases. Do you have size criteria for metastasis to resect? And then the question is, some are very, very small lesions, so very difficult to identify by VATS. Do you prefer another approach then, if you have very small lesions, or what do you suggest in this about the size?
Well, now the CT is very sensitive and very accurate, so you have chances of overestimating the extent of disease and not of underestimating. So you start with an idea, but of course micro nodules below the 2 millimeter, there's no way to decide whether they are metastatic or not. So we start with the frozen section on these micrometastatic nodules, and if they are all positive and we realize that it is unfeasible, a complete resection, we stop the procedure. The only exception to this is probably osteosarcoma, because in osteosarcoma we have a good survival above the 10th, but also because in osteosarcoma it is easier to resect all, even below 2 millimeter, because they are easy to assess, even deep in the lung, while in the other soft sarcomas it can be extremely difficult to locate. So when we are in doubt in a patient, we offer him the privilege of a surgical attempt on one side and watch carefully the evolution in the following 3-4 months. And we only proceed to contralateral surgery if the operated lung is clean. So we use the time not as a waiting before, but as a waiting period after the first metastasectomy.
Okay. Any maximal number of lesions you can operate on?
Well, we've done up to 100, I think, in osteosarcoma, but I would not recommend that. I mean, we had a program of systematic metastasectomy in children with osteosarcoma. We have one or two patients who had a long disease-free survival after more than 40-50 metastases. But this only applies to specific sarcomas, certainly not to others. And of course, adenocystic carcinoma of the salivary gland is another area, but I think they rarely reach the extremely small size of the sarcoma. So there can be multiple lesions, but usually they are not millimetric.
Okay. You already touched it briefly, but the value of CT mapping versus the manual palpation of the lung, for you, the CT is as good?
Well, I was one of the people who advocated systematic principle sternotomy to do bilateral palpation in patient without a single lesion on the opposite side. We have abandoned that. We have demonstrated that it is not necessary because the CT has improved dramatically, and there is no advantage in trying to do bilateral resection. So in the same way, we don't advocate open surgery for solitary lesion because we think this is no longer necessary. Sometimes, occasionally, we have a problem, as I said, of overestimates because the CT sees a lot of granulomas that may be associated with metastatic lesion, and so you have a mixture of benign and malignant, and it is not always easy to decide which are the benign and which are the malignant, but these are special cases. In our experience, the difference between a VATS is a 3-4 centimeter incision for VATS and a 6-7 centimeter for a minimal thoracotomy with rib spread, limited rib spread. But we usually don't do it to palpate. We do it to do precision resection of a small, deep lesion deep in the lung. We don't want to do a lobectomy for 1 or 2 small nodules in the center of the lung.
Okay. Going further on that answer, for localization, if you have only one metastasis, but it's really deep in the lung, it's going to be difficult to find it back to a VATS approach. Do you use any localization techniques on beforehand and a coil placed in situ, or do you do a small open approach in that cases?
We prefer a small open. We have not been happy with the localization. We think the most critical thing are soft lesions, deep soft lesions after chemotherapy. These are the most challenging lesion, and these are not traced by these localization instruments, even because they are multiple and non-palpable and sometimes excavated, so you cannot put anything inside. These are the really challenging metastasectomy.
Okay. How many times do you operate for relapses? I think for osteosarcoma you can go quite far. Yes. How far do you go for colorectal cases?
Well, it depends on the number of lesions, but in the series I showed you, approximately half, all tumors, all primaries together, approximately half. Let's say 2/3 at one single operation and 1/3 as multiple. But in colorectal, for example, half of the patient have multiple resections, have multiple operations. So it depends on the primary. In sarcomas, is probably the other way around. So 2/3 have a multiple operation, and less than 1/3 as a single operation. So it depends on the primary.
Okay. Here another question was: would you consider doing a lobectomy for multiple lung metastases in one lobe, or do you prefer an open resection of these lesions then to save this lobe?
It depends if that lobe is the only affected the lobe, and it depends if it is lower lobe or upper lobe, because if you take one lower lobe, one right lower lobe, you may compromise any chance of doing salvage surgery on the other side. So it depends. If you have a disease confined in one lobe, if there is nothing else and the prospects are good and you have no options, to have to do it. But if the alternative option is open and do precision, I prefer open precision than sacrificing a lower lobe that may jeopardize the future.
Mm-hmm. Okay, a lot of questions are still coming in, so it's very interesting for everyone. Let's have a look. About the site of recurrence. If you did it in metastasectomy, do you have any idea where it comes back? Is this do you see this more in a staple line of a VATS resection, or more after precision resection with maybe a smaller resection margin? And what is your recommendation there?
I don't have a clear data on that. But obviously there is here a bias, because you do VATS stapled metastasectomy for a solitary lesion, peripheric solitary lesion, and you do precision for multiple deep lesions. Mm-hmm. So it is obviously more likely to recur, but doesn't mean that it recurs at the site. Almost never recurs at the site of resection or precision resection. It recurs in another side of the lung, maybe even the same lobe, but not adjacent to the resection. So it is it's related to the prognosis, intrinsic biologic prognosis, not to the resection itself. I don't think it is very rare that we have a local relapse after precision along the suture line.
Mm-hmm. Okay, and then a question we also see quite often in our institution here about patients with head and neck squamous cell carcinoma, and there appears to be a pulmonary nodule, also squamous cell carcinoma. We never know, is this second primary or is this metastasis, and how do you treat this kind of patients?
If it is one nodule, we treat as a primary, because it is a primary in the vast majority of cases. If there are multiple, they may obviously be metastases, and they may recur, and so we treat it conservatively as with a parenchymal sparing approach, but we do always sampling, nodal sampling in these patients. But if it is a solitary, we assume that it is a primary.
Okay, and then we already talked about the sternotomy in situation of double-sided metastasis. You still prefer to go both sides at the same time in one single operation, or do you do a staged operation in 2 stages? Left side, right?
We do a staged operation. We use a sternotomy only if there is some sort of mediastinal involvement for other reasons. But if it is only bilateral disease, we use a stage. As I said, we have abandoned.
Okay, and do you do then two sites VATS at the same day, same operation, or do you leave some time in between?
Oh, if it is only one nodule each side or 2 nodules each side, we may consider that. It is time consuming, and the planning it's not something that you can offer to everyone. But in selected cases, yes, if there is a good reason to save 1 month, we do it. Otherwise, we stage 30-40 days. Okay. But the reason for bilateral approach is also that doing precision resection, apart from VATS, but precision resection from the midline is extremely difficult. I mean, to get back of the lower lobe and do a precision resection through the sternotomy is really a hassle. We don't think there is any. And the people, especially if they are young women, they don't like the midline scar. So I mean, they are really not happy. And we are not happy either.
Okay, then for the chemo-sensible tumors, you recommend lung resection, so after chemotherapy, but sometimes you see that these lesions are shrinking a lot. It's very hard to find them back. What is your recommendation on that? Do you evaluate after a certain time of chemo? Do you wait until they're completely gone, or it's a bit the same in liver metastasis? It can be very difficult, very hard to find the lesions.
You are right. You are right, but we think that the benefit of a shrinkage overcomes, you know, the difficulties. But of course, once you have reached the biologic effect that you wanted to achieve, you go ahead. So I mean, if you have a response after the first 2-3 cycles, you can go on to 4-6, and then you operate. It is unlikely that you don't find the lesion, but sometimes, as I said before, sometimes you cannot palpate the lesion. This is it is rare, but it may happen. But on the whole, I think there is a benefit in terms of a permanent control of disease by the chemotherapy.
Okay, we are about 1 hour normally spoken. We stop here, but it seems to be very interesting for everyone. Maybe if the audience agrees, we can still go on with some other questions Professor Pastorino prepared for you. If not, we can also close here. Please, to the audience, can we have some other questions from Dr. Pastorino to vote on, or has it been enough? I'll just launch them if that's okay for you, Dr. Pastorino.
Yeah, of course.
I'll just.
They can also answer. They can also answer after, and we can continue through the mail. But I have time. I can go ahead for another 10 minutes. No problem.
Okay, so I'll publish this this further questions, and then people can vote on that. So, one question: what is your most used approach? Just to know, what resection technique do you use? Staples, precision, or based on the number and site? The fifth question: what about nodal metastasis? So you heard the opinion of Dr. Pastorino, but maybe you have another opinion on that. What about systemic therapy? Same there. And what about other local therapies, being RFA, SBRT? So please vote on that. I'll have a look if we have any other questions. I don't think that's the case. But if patients have metastasis to other organs too, do you also perform the other resections in the other organs?
Well, liver for colon cancer is a standard. Certainly, there are more liver than lungs, and there's no question.
You don't do it yourself, huh? I think that the question was, do you do it yourself? You do the lung metastasis. You don't do the liver metastasis.
No, of course not. No, but apart from the fact they are usually treated with the liver metastasis before lung mets develop. So it is usually, liver first, lung second.
Okay. Let's go back to the polls. So in the third question, what is your most used approach? There we see that almost, that 44% is answering VATS or based on the number of site. That's about the same, 45%. And the minority is going for open, but indeed that depends on the number and site again. Question 4, what resection technique do you use, staplers or precision, or based on number and site? And half of the people are saying based on number and site. So I think that's a little bit what you were telling us. Also, what about nodal metastasis? 1/3 is saying not for surgery. Almost 40% is saying based on the resection on the resection volume. 5% is saying in one only, And again, almost 1/3 is saying 1 and 2 after induction. Do you have any comments on that?
Well, I think it's very reasonable. It is very.
Okay, and then systemic therapy, half of the people are saying chemosensitive tumors only, and indeed this is a little bit what you also have been saying, and the rest is 1/3 always before surgery. So the systemic therapy. So most of the people are using systemic therapy as well. And the last question was, what about local therapies, other local therapies for lung metastasis? And their majority is saying in high-risk patients only. And let's say I adapted this question a little bit. 60% is also saying this is not my call, but the oncologists are referring the patients. So if you don't see them, they are going for another local therapy. This is also a possibility, of course. Okay. Today was a great ESTS webinar again. We had 140 live attendees and 400 registrants. So this was a great success again, I think. I apologize for the technical problems we had at the beginning of the session. I don't know why this happened, but I apologize for that. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Dr. Pastorino, for this webinar today, and you, the audience, of course, for your interest and interaction. This was also the last educational webinar for this session. So on behalf of the ESTS Learning Affairs Committee, I would like to thank all surgeons and other affiliated healthcare workers around the world who are watching our webinars and are interactive with us. You are with more than 1,700 now in more than 60 different countries. We will send you a survey in the coming weeks to understand what you think of our educational webinars and how we can further improve them in the future. We'll be back in October with a new series of webinars, and this time not only with expert lectures, but also with pro-con debates and multidisciplinary discussions. So thanks again, stay safe, and I hope to see you back in October. Thank you.
Thank you. Great.